Until about the last 1 year or so, I was not using MRD in the commercial setting for patients who are not on clinical trials requiring MRD analysis. But now for the last 1 year or so, I think with all the emerging data of how important MRD might be in terms of considering stopping treatment especially, I do send out MRD testing much more frequently, mostly near the point where I'm thinking about stopping treatment. For instance, CLL14 data that led to the approval of venetoclax plus obinutuzumab, finite therapy for 1 year of venetoclax. If people are not on a trial and I'm giving them that frontline therapy, then I'd like to check the MRD before the end of that 1 year to see if they're undetectable MRD, I feel better stopping their venetoclax at that 1 year mark, as do patients. If the MRD is still positive, then we discuss, do we keep going for a bit longer, or do we still stop and just observe things, and just that we know where we stopped in a way. So I do use MRD a lot more now, and I think that all these prospective trials are going to be showing the data over the next year or so that of its importance in these CLL patients. Even in the relapse setting, we do it often enough based on the Murano trial. Like if we're stopping venetoclax after the 2 year mark for the combination of venetoclax plus Rituxan, then I like to check an MRD and just know where I stand with these patients in terms of detectability or undetectability. And I think it just is reassuring for patients and also gives us the knowledge of where are we stopping treatment.